around enough that nobody totally forgets. My name is Mark Kieran. I'm from the Dana-Farber Cancer Institute in Children's Hospital, Boston. And what I was going to do today was talk a little bit about where I think you've been and hopefully where you're going to go. And I think that there are a couple of ways to do this. We could cheer a lot about the success and progress that's already been made. We could dwell on all of the things that still need to be done. And what I'm going to do, I think, is try and balance a little bit the two of them, because in some ways they're both important. So I'm just going to start with the journey of 57357 as I see it, which will obviously be different than you, because by the time I first heard about this, there was already some construction going on. By the time I got here for the first time in February of 2008, you'd already been open for 6 months. But at least it was interesting because things here are not as different as one might think from other places. I think yesterday and today are really about where you are now. And the quality, the depth, the volume of the data yesterday is an indication of the strength of all of the opportunities you have. And so I think the real question now is, what's the future? Because I think that's really what's going to end up defining over the long term this institution. So I guess you can't really start this session without congratulations. And congratulations can be for just having gotten the place built, which many people still consider a miracle, for keeping it going 5 years. Happy birthday. It could be about the revolution and all of the things that are happening a couple of miles downtown, because obviously all of those events to some extent reflect what this institution can be and should be. And in some ways, I think the revolution is going to be an important guide for the way this institute develops. I think in some ways, the actual revolution, the day that Mubarak left, the day that things changed, in some ways was the easy part. The hard part is the 20, 30, and 50 years that come afterwards, when it's all of the things you have to do to solidify the revolution, to move things forward in a way that actually makes that change worthwhile. And while that's the most exciting part with the crowds and the flag waving, to some extent this institution after 5 years is at a crossroads of determining what's going to be next and what are the things we're going to do. And as I'll point out, I think you have all of the components together. Now it's a matter of actually doing it. So I think this sums up the way many people kind of think and feel. Institutions that make physicians treat all patients so that there is no expertise in brain tumor, leukemia, solid tumor. Every doc has to see every type of disease, which means it's hard to develop expertise and knowledge. That without that kind of expertise and knowledge, you end up with a relatively limited number of treatment options or protocols on which to treat those patients. Things that we think are going to be important in terms of moving stuff forward. That obviously, if you're scattered from one clinic to the other, it's hard to really get a good publication record. Because, too far? Is that better? I've never had people say they couldn't hear me before. So this concept that publications are important to some extent come out of the ability to focus. And then what I think is the biggest problem is when you go from patient to patient, when the only thing you're trying to do is just keep your head above water in terms of the therapeutic requirements, it often seems like, and it's the example that Sharif raises all the time, it's like being a mechanic, that you're kind of going through the motions, you're doing all of the right stuff, but there's little personal satisfaction or development that comes with it. Now, you would look at this kind of progress and say, well, clearly he's talking about us because these are the issues that we've had, and we've talked about some of these, but in fact, I'm not talking about you. I was actually talking about us at Harvard. So what I wanted to do when I was thinking back to where we've been, and by we I mean both you and me, when I first was given the directorship of the brain tumor program at Harvard, which is more than 5 years old. These were all of the clinical trials that we had in pediatric brain tumors. So none for neural tumors, including medulloblastoma, none for germinal cell tumors, none for choroid plexus, none. We had one radiation study for low-grade gliomas. And for those of you in the audience know that the one thing you shouldn't be doing is radiating low-grade gliomas. So the one protocol we had wasn't even a good one. This was the entire extent of our therapeutic plan in 1997 when I started the brain tumor program. Not a lot different than what you guys were doing just a couple of years ago when you first got here. By January 2003, we had multiple protocols in every single disease type for newly diagnosed as well as relapsed. We had them from all different places, studies that were unique just to the Dana-Farber. We decided to do some things on our own because we thought we could answer the question. Some things we did through consortium, like the Children's Oncology Group or the Pediatric Brain Tumor Consortium. It wasn't so important exactly where they came from. What was important was the ability to begin to develop things in a way that solved some of those initial problems. We opened up a large number of both phase 2 and phase 1 clinical trials for patients with relapsed or poor prognosis disease, again, as an opportunity to move things forward. And again, all of those things happened in an approximately 5-year period between the start of the program and when I showed these. Not only is it about the treatment, though, I think as everybody has recognized, and as Kathy will get up momentarily to talk about nursing and some of the other specialties, we opened a whole bunch of protocols on the underlying biology of tumors that had nothing to do with treatment, a whole bunch on the side effects of treatment and how one could mitigate it so that you got better outcome with less toxicity, all kinds of epidemiologic studies on some of the tumors that would allow us to better understand our patient population. We already talked about, oh, I see, maybe I have to do this one. So this is an example of all of the phase 1 studies we had when I took over. So, and this was for all of the groups for solid tumors and brain. And as you can see, in 1997, we had one study. We had two studies from the Children's Oncology Group, solid tumor, and we had one study from brain tumors. That was the entire depth of our portfolio. You can see by 2000, 3 years later, we had almost 25 protocols now open for those same things. And the question is, what's required to actually do that? These are the number of patients we accrued. So we were averaging 1 to 2 patients a year when we started. When I started, we were up into the 20-25 range only a couple of years later. Publications, obviously, if you're not doing very much, it's hard to have much, and you can see an almost decade-long period when we were averaging far less than the publication output you have here. By 2002, we were more up to kind of 10 papers a year. Right now, we average the brain tumor, just the brain tumor group, averages about 30 publications a year for that group. Obviously, the leukemia group would do similar, the solid tumor group, the transplant group, et cetera, so that we can actually end up with a large number that reflects the diversity and expertise of the program. And then, well, if you're publishing and you're opening protocols, you now have an opportunity to competitively compete for grants, which brings in money and generates interest and allows you to test new ideas, all of which feed to new protocols, new publications, and more grants. And to some extent, this is a model on which I think 57357 is ideally situated. Because not that long ago, you started, this represented the care that many of you came from. And again, it is absolutely remarkable that 12 years ago, where we stand today was an empty lot, and 7 years later, this institution. But to some extent, I think what we have to do now is move away from what you've built. It's spectacular, it's shiny, it's got all of the great stuff. I think the real question now is what happens on the inside and how do we optimize that kind of output? So I think that there are some other changes that wouldn't have been true at the time that this institution was being planned. I think oncology in general has made a major shift away from trying iterations of chemotherapy, which in some ways were the easiest treatment protocols to do. You just take the drugs that are available and you intensify one, you de-intensify another, and you see if it makes a difference. I think people are moving away from those kinds of studies. And to some extent, I think this is going to be one of the opportunities that 57357 can take advantage of. Our goal now is to understand the disease, not to continually just randomly throw slightly different iterations of therapy at it and see if we get something new. I think we've learned that that's unlikely to be true. That if we really understand the biology, we can understand how to basically invent therapies that are rational and will work. And that if we begin to understand the way all of these fit together in the context of the patient, the pharmacodynamics, the pharmacogenomics, those are the things that I think will actually become important in terms of developing effective therapies. So what does this mean? I think if there were one word that kind of, that provides the meaning for where we go from here, it's multidisciplinary. That surgeons can't know where to operate unless the radiologists have done some of the more sophisticated imaging to guide them to where to go. The pathologists need the material in a way that will not just allow them to make a histologic diagnosis, but the kinds of analyses that will provide for the mutational profiles, for example, that will help guide therapy. That the oncologists can't just be giving chemotherapy by themselves. If you don't understand the nuance and biology of those tumors, it's unlikely you can be effective. The second most important thing is working together. And working together is really, I think, just another way for multidisciplinary. You have the multidisciplinary ability at this institution, but just because you have all of the services, actually putting all of those services together, in some ways is, I suspect, the hardest part. It's probably harder than actually building the building. And we all understand that we all have personal beliefs and desires. We all have personal biases. We all have our own egos. And the question is, how do you make a somewhat sophisticated group of independent, thinking people work together for the better goal? So when I told you, for example, we get about 30 publications from my group, those are not 30, I'm not on every one of those publications. That's not the goal. But if you begin to see the goal as the larger group, and that you will benefit sometimes in one thing and not in another, but that's okay because the time after you will benefit again. If we see that as the primary goal, I think to some extent you have all of the other components necessary. So again, the one thing I think most foreigners would never understand or expect of this institution is the breadth of your technological capabilities. You either have or are getting all of the latest gadgets and gizmos that one could want to diagnose pediatric brain tumors. And all of the things on this are things that your radiologists can already do. That combining nuclear imaging and MRI, CT is something that you already do. Intraoperative MRI, as you heard Sharif mention yesterday, is coming. The ability to kind of put some of that onto functional imaging is, of course, how to improve further the outcome, but these are all things that you can already do. Advances in molecular pathology, not just immunohistochemistry, but a more detailed understanding of the actual tumors is, again, something that we saw from the pathology and clinical lab groups yesterday, you already have enormous sophistication for. This is an example of the gene expression arrays from Scott Pomeroy. This was the first gene expression array for pediatric brain tumors published, which is why it was published in Nature. This is only 10 years old, which means the entire kind of Europe and North America are really only 10 years ahead of you, and you can make up a lot of that ground by not repeating many of the same mistakes that I think we made earlier on. that you have advanced radiation techniques that are equivalent to anything we have in North America or Europe. So it's no longer a question of we can't treat our kids because we don't have the stuff. You have all of the stuff you need. And for those of you that remember Dr. Liligam Narova, who's one of the neurosurgeons from Boston that comes over with me from time to operate here, she actually thinks your operating rooms are better equipped than ours are in Boston. So if you've got all of that stuff, again, the question is going to be, how do you start working together to integrate all of those aspects for optimization of patient care? I think to move forward, CCHE really needs, you need all of the technical requirements, but you have all of those things. And now I think really becomes the hard part. Are you willing to put the effort in to work together in a way that sometimes de-emphasizes your role solely for the betterment of the institution? And I think that's where we will kind of learn which groups do well and which ones don't. So where are we now? Well, you're adding capacity to meet your patients' needs, and obviously we're doing everything we can to support the development of the expansion of the hospital. Sharif, as always in his forward-thinking planning, isn't just adding a building, because if you add a building, you need all of the infrastructure that goes with that, the nursing, the lab support, the physicians, all of those things. But I hope everybody here realizes that all of that is part and parcel of the plan. That to some extent, where we define where you are now, I think was exemplified by yesterday, and I have every expectation will continue today. The results you have are outstanding. They're with enormous numbers. Are there things we can make a little better here and a little better there? Absolutely. Those are things we're going to continue to work on. But you're already quite far ahead. And I think as we develop a plan for moving forward, it's time we not talk about where so much we've been. I think the real focus has to be how do we get where we're going? Because as I've said, I really think what you've done so far is the easy part. That Sharif often talks about this concept that you can't improve what you cannot measure. And to some extent, I think that's absolutely true. This is an example of a gene expression array of a variety of different pediatric malignant gliomas. And as you can see, they have enormous heterogeneity because it's not the same disease. There are all kinds of variations in it. And so I wanted to kind of change his wording a little bit to, you can't treat what you cannot measure. And as we really go forward, I think the requirement, the onus on 57357 will be to begin to think about things not as, here's another child with neuroblastoma. There's something unique about that child. Every child can teach us something about how to improve the disease or the treatment or their care, even if it's palliative care, so that it's better the next time around. And if you see it that way, that's research, that's moving things forward in a way that I think are particularly important. Because I think we are coming to the age where understanding the genetics and the underlying biology of disease is about to change the way we are doing medicine. That this concept that there are specific mutations, that even for two patients that have exactly the same tumor, if you have the same tumor, but there are different mutations responsible, it doesn't matter that you both have a brain tumor. What you really need are treatments that recognize the unique characteristics of your tumor. And that not only is it going to look like this, obviously it's going to be more complicated because no tumor makes it so easy that there's just one mutation. There are going to be a whole bunch of mutations, and only when we find the right combinations. And remember, the right combinations don't say, let's try to get rid of chemotherapy, let's try to get rid of radiation therapy, let's try to get rid of surgery. These things can all be done together so that we optimize the maximum of both. So the idea isn't to put any one of us out of business, it's to make sure in this multidisciplinary program that everybody works together to develop the most effective therapy. But I think there is no question this concept of molecularly defined disease is coming forward. It certainly started in leukemia, where although they don't have a lot of molecular inhibitors, they certainly understand the importance of some of the underlying genetics in terms of guiding the kinds of therapy. And you saw that yesterday in the ALL group, in the ALL presentation. But this is also now happening in medulloblastoma, low-grade gliomas, neuroblastoma, and so forth, which means I think the principles are going to be both generalizable and expanding. So what's next? Well, I think, again, the key is no longer so much we need more stuff, because with what you've got and with what Sharif's already planning, you're about to have more stuff than anybody else. You've got more patients than virtually any other group in the world could even imagine. And remember that if we try to understand treatment, it requires both the treatment and the patients being treated. And to some extent, you people here have something that virtually no one else, certainly no one in North America or Europe have. You actually have the patients on which to ask questions, answer questions, and move therapy forward. And in some ways, well, Leslie and Julie and I are kind of sitting there salivating over how incredibly fortunate you are to have this resource. The key now is how to use the resource. But what you really need is now you have to commit the time, the energy, the focus, and the willingness for interactions to, I think, actually take advantage of that. The disease groups, I think, are a phenomenal start to where we have to go, but they are just the first level in, I think, solving many of the issues that have to be done here. There are a number of other things that I wasn't going to talk about just for brevity of time. The fellowship, that collaboration between yourselves is important. Collaborations with others is equally important. The beauty of the fellowship, and I have to admit, when this idea first came up, I don't think any of us were absolutely sure this would ever actually happen. Now we're literally months away from getting our first American Academy of Pediatrics directed fellowship program for general pediatric oncology here for a couple of reasons. One, it's a great way to build interactions. The more Egyptians that understand us and the more of us that understand Egyptians, the better, the stronger, and the more viable the interactions will be. That as we talk about all of the stuff that's happening, including the addition of the new patients, you are going to need the support of multiply well-trained other people. And while I'm going to not so much talk about, but at least mention the concepts of the fellowship for pediatric oncology, I suspect that when Catherine gets up to give her talk on nursing, she's going to say exactly the same thing is true, that as we develop training for nursing, the two together will become critically important in terms of moving things forward. I think the other reason the fellowship is important is that it forces people from here to come to the United States, and I think that's a wonderful experience. Remember, I'm an immigrant to the United States as well, so I actually had to go there once to find out what it was actually like before moving and working there. And I think that the opportunity for that kind of interaction cannot be understated. I think having Americans come here that you can meet and interact with is equally important. The other thing, and it's unfortunate that some of the senior leadership from the Institute is not here today, because to some extent, they're the ones that I think should see what the groups are doing and how important the next step is going to be. If the next step is going to be collaboration, the fellowship programs alone is not going to be sufficient to say that we're working with people on the outside, nor are we working with people on the inside. You have got to go to meetings. You have got to meet people. The best science, the best discussions at meetings doesn't happen when everybody is sitting in an auditorium listening to someone speak. It's during the coffee breaks, it's during the lunch breaks, it's during the dinner programs. And if you are not at those things, you don't take part in those discussions, you don't know what's happening, you can't take part in what's happening. And to some extent, the worst thing in the world would be to have this institution and not allow it to reach, I think, its potential. So developing collaborations is obviously not easy. And as you know, I think one of the things that 57357 has to be very careful about is that the collaborations have to be based on mutual respect and benefit. That you're right now a huge opportunity, a huge resource for other institutions. I think every single collaboration you do has to have as a larger goal, not just doing something because you can now say you're doing something. It is, what do you get out of the collaboration? Not a middle authorship in a paper. What comes back to this institution that allows you to make an actual difference in terms of development of a protocol, in terms of a translational project, in terms of basic research through the new Research Institute? Every single time you do this, I think those are the questions you have to ask. And if you ask those questions, I think the kinds of things, some things you think are great ideas, you may have to turn down because they don't have the kind of benefit that are needed. But overall, if you teach the world that the strength you have in volume and expertise makes you a perfect partner, not simply a provider of material, I think the opportunities for you and your staff are astronomical. But of course, how can you do that if you don't go to the meeting so they even know who you are, what you're interested in, or what you want to do? I was going to kind of just finish off with talking a little bit about what I think are some of the actual opportunities. And originally, I was going to put them down in specific detail, and some of them I had spoken to some of you about yesterday. But then I actually thought my definition of what are some of the things you should do is to some extent exactly the wrong approach. You have to sit down and decide what it is you want to do. The expression that you can lead a horse to water but can't make them drink is true. Just because I'm interested in a project doesn't make it the right project for you. So what I was going to do is just briefly mention what I see as some of the larger opportunities in the hopes that people here will finally begin to jump on some of these in terms of moving forward. So for example, in the clinical realm, I hope that people here are not satisfied just applying the standard of care in North America and Europe, the protocols that you're currently using, as far as you want to go. That I think those were a great starting point. They allowed us to standardize care. They allowed us to make sure that we understood that everyone was getting treated properly. But I think at some point, just like the lack of protocols, novel protocols we had in Boston in 1997, I think what the groups now need to do is sit down and say, okay, what are the questions we want to ask? Because we can design the protocols that will do those and actually answer some of these questions. Not everything can be a randomized trial, but some things are ideally suited for a randomized trial. And remember, the one advantage that you have over almost any other program in the world is that you actually have the patients on which to do randomized trials. So in North America, in order to get enough patients, an average of between 100 and 400 patients, depending on the disease and the question being asked, we typically need 250 different pediatric hospitals from all of Canada, the United States, Australia, Switzerland, and Belgium, I think it is, have all joined together to create a group called the Children's Oncology Group. And the goal of the Children's Oncology Group is to do studies, including randomized trial. 252 different hospitals all working together. You can imagine how hard it is to get all of those people thinking and agreeing the same way, which means many of the things we do are not particularly imaginative or even meaningful, because by the time those committees have made any decision, things are not nearly as precise as I think they ought to be. When you looked at the numbers that got discussed yesterday, your 400 leukemics, your 250 AML patients, your 100 randomized brainstem glioma patients, your 180, I think it was, medulloblastoma patients, every one of those populations is basically a randomized trial waiting to happen. And the reason why a randomized trial is so important is that a randomized trial actually allows you to move a field forward. when you compare two things, you can now actually figure out which one is better. When you just do a single-arm trial and you get a result, you have to compare it to other studies that were not exactly the same, not done at the same time. You're never sure whether things got a little bit better because of the way you're doing the comparison, or whether it's because you actually made things better. And so of all of the resources you've got, your patient population, I think, is number one, and I think it's where you ought to put a lot of effort. The smaller studies, like the things that we're forced to do in North America, because we don't see enough patients, about 1/10 the volume that you do, is what we need to do is we do small pilot studies where we take 10 patients, we treat them in a certain way, and if the results look promising, we then look around for a group that's willing to do a randomized trial that could actually answer the question definitively. So whether somebody here has a small idea that you just want to test on a small group of patients, like a pilot phase 2, so that you can then convert it to a randomized phase 3, is, I think, you're ideally suited for that. Another area where I think you have enormous potential, although I recognize that it will require some changes or rethinking of some of the both cultural and ethnic issues that are part of Egypt, is the concepts of phase 1 therapy. As you know, in phase 1 therapy, we give new experimental drugs that are not yet proven to work to patients because there's a rationale. The drugs could cure that kind of tumor in an animal, and it's now time to see whether we want to do that in patients. Right now, almost all of the world's phase 1 testing happens in Europe and North America. Virtually no other country takes part because there are questions about the ethics of it. But the ethics of treating a child with a therapy that's not likely to work when there may be newer ones out there than are, I think also has an ethics to it. In my meeting 2 weeks ago with two of the largest pharmaceutical companies in the world, Sanofi and Roche Genentech, both of them have started large international programs in India and China and are looking for other partners who would be interested in beginning to understand whether some of the molecularly targeted drugs that we've been testing in North America and Europe will function similarly in other populations, particularly those of the developing world. I could easily envision 57357 as the world's leader in developing novel therapeutics for developing countries. And that doesn't always just mean some highly complicated new experimental drug. That could be therapies that are more situated for people that live in remote areas that need therapeutic options where they're not going to be able to get a transfusion 3 times a week, and therefore the kinds of options, the treatments that you're going to give them need to fit those populations. And that you, I think, have the ideal population for do that if you're willing to kind of see that as an opportunity. One of the things that you might think about, for example, is you have a brain tumor group, you have a leukemia group, you have a Wilms tumor group. Maybe you need a relapsed and kind of developmental therapeutics group that will begin to think about what you do for the relapses or what you do to learn about some of the other drugs or treatments that might be appropriate in this population. And here's another opportunity. There's virtually no place in the world that has your volume that's currently doing that, which means here's an opportunity starting today, I think, to lead the effort. And if you lead it, you will then be invited to meetings, which gives you an opportunity to interact, to begin to publish, to begin to get grants, and the whole cycle kind of picks up from there. And then perhaps what is the hardest one right now, and where perhaps international collaboration is the most important, is the biology. Again, you have more samples than anybody else in the world. And the question is how to convert some of those collaborations for biology so that there are things that can come back to Egypt and stay here so that you begin to do some of your own biology. It's not that you want to compete Western blot for Western blot or gene expression array for gene expression array with programs that have technical capabilities that are evolving so rapidly it's hard to keep up with them. But you certainly have the opportunity, I think, to guide some of the biology that both others are doing with your samples and that you need to be part of. So I'll stop there because let's see, we're now half an hour over already. Again, it's congratulations, but it's not just congratulations for your 5th anniversary. It's congratulations for everything you've done to get here. That on a personal level, it has been really a remarkable experience. This is, I think, I don't know, about my 10th time to Egypt. It's my wife and children's 4th time. They're down in Marina on their way back up later on this afternoon. The ability to witness the changes that have happened, not even excluding the revolution, although that's certainly been a fascinating part to watch. The culture, the language. I knew nothing about Muslims. I knew nothing about Arab countries. And I suspect that that's true for most people in every circumstance. We know only what we know, and that's usually designed on what we see around us every day. I grew up in Canada, and I remember when we moved to the United States, where there are a lot of black people, colored people, whereas in Canada there are virtually none. It was a whole new experience for me. And every time I come here, I continue to develop an experience with what a kind of magical culture, what a magical group of people Egypt has. I know the revolution is both exciting and not easy, and to watch you go through that, I have to admit, has been an absolutely fascinating experience, and one that I want to continue to kind of share. My goal, though, is to recognize that I'm here to help, that people that come to help can only help so much, that the real change, the real progress happens from within you, and that to some extent what we do, like voyeurs, is we come and watch what you're doing, and we try to help a little bit, but mostly we're just amazed. And I want you to always know that we are here to help, and we'll do everything we can to make things better as much as we can, but that to some extent we're now looking back on you to say, show us what the next steps are going to be. We'll do everything we can to support them, because we believe in this institution. We believe as strongly in you as we hope you do. And I say, I hope you do. I know you've been overworked. We have an expression in English that all of us are overworked and underappreciated. That's part of what life is about, both from our spouses, our children's, and sometimes our work. Let me know that you're immensely appreciated over where we are. We cannot believe the volume you do, the stress you're under, the complexity of what you have to do. To some extent, I think doing some of these things will make it better. It's an opportunity, I think, for all of you. And in that sense, I want to actually thank you for all of the time and energy you've given us. You've allowed us to take part. I know with Sharif at the helm, things will continue to develop. We're going to be part of all of that. So congratulations to you, and thank you for letting us be here.